Hi, my name is Clay Josephi. I'm with Tahoe Emergency Physicians and Barton Health System. The topic of today's talk is emergency department procedural sedation, and specifically, we're going to focus on how we do things at our facility and the policy and procedure, and we're going to talk about some nuts and bolts stuff, and then we're going to get into some of the more interesting sort of pharmacology and some of the more important concepts of emergency department procedural sedation. Our objectives today, as stated, first and foremost, is to review and introduce the Barton Health System EDPS, or Emergency Department Procedural Sedation policy and procedure. We're going to review some of the key features and some of our requirements, both in procedurally and also documentation requirements, and just how we do things so we're all on the same page and so we can standardize care. We're going to review some of the commonly used drugs and the pharmacological agents and their clinical effect, and specifically we want to hone in on how these drugs work, what are the doses, what are the right patients, and we're going to talk a lot about adverse effects so that we can be prepared to both counsel our patients and to perform informed consent, but also to manage these adverse effects, which are rare but definitely occur. And we want to really kind of get a really solid handle on, what to expect and what are some of the unexpected adverse events that occur with procedural sedation and analgesia in the emergency department. So this talk is going to serve two purposes. One is just a kind of a purely educational imperative and an educational tool, but then also it's going to serve as some credentialing for emergency department providers who provide sedation and procedural sedation in the ED. So to get started, any self-respecting sedation talk is going to start with the sedation continuum. Now, I think this is important for a number of reasons. First of all, is that this is how I guess the regulatory bodies sort of define the world of sedation. And when it comes down to it, when you get into the realm of moderate and deep and general anesthesia, you really have to kind of follow some protocols, and there are some specific requirements from the regulatory bodies that we are performing in our hospital. So when you get into moderate sedation and deeper, really that's what this protocol really sort of applies to. Now, it's important to understand, though, that sedation in and of itself, or I guess a better word would be sedation and analgesia and anxiolysis, because it starts with analgesia and anxiolysis, and really that's the administration of a pain medicine for pain control, or the administration of a anxiolytic medication such as a benzodiazepine for just anxiolysis for people who either have underlying anxiety, or the procedure that they need is causing or provoking some anxiety or making them scared of in any sort, and you're just trying to facilitate the procedure. So it's important to start at the bottom. And that's called, according to the definitions, analgesia and anxiolysis. And the reason why it's important to remember this is because if you're providing somebody with a single dose of an opioid or a single dose of a benzodiazepine for the purpose of analgesia and anxiolysis, it's important to call it that and to document that you're performing anxiolysis and analgesia as opposed to sedation, because when you do start getting into the realm of sedation and moderate sedation, then that's when it triggers this protocol, and we have to follow this policy and perform the paperwork. But when you're just providing analgesia and anxiolysis, that is just baseline clinical care. The definition of analgesia and anxiolysis, of course, is just to administer a drug for the purpose of pain control and or the amelioration of anxiety. Importantly, consciousness is unaffected. So then you move up the scale and deeper into the deeper levels of, quote unquote sedation. You've now moved away from anxiolysis into sedation, and you get into what's called moderate sedation. And this is something we're all really familiar with. It's very commonly performed in the hospital. Not very much in the ED, although certainly represents about 5 to 10% of our cases are performed with moderate sedation. And this is typically just fentanyl and midazolam. And the definition of moderate sedation is a drug-induced depression of consciousness. So now you're starting to see some alterations in consciousness. But specifically with moderate sedation, the definition is that the patient is still responding purposefully to verbal commands. And cardiopulmonary reflexes are typically maintained. Occasionally you'll see a little bit of hypoventilation that'll respond to supplemental oxygen. But typically cardiopulmonary reflexes are maintained in this level. And typically, again, this is achieved using fentanyl and midazolam in our facility. As you move up the scale and you start getting into the administration of general anesthetics, such as ketamine and propofol and etomidate, which are the main drugs that we use in our facility, you move into deeper levels of sedation. It's important to understand what the regulatory bodies use as definitions. So dissociative sedation is really about ketamine. Ketamine is the single dissociative agent that we use, and it's defined as a drug-induced depression of consciousness. Again, consciousness is impaired, and a cataleptic state that is characterized by amnesia and analgesia. Typically with ketamine, cardiopulmonary reflexes are maintained. I say that with a little bit of a caveat that we're going to get into, in that ketamine can absolutely affect your respiratory and hemodynamic systems, and we'll get into that. But in general, the cardiopulmonary reflexes are maintained using dissociative agents. And then there's deep sedation, which is generally what we do in the emergency department. We do, I think, 90+% of our cases of procedural sedation in the ED at Barton involve dissociative or deep sedation. And deep sedation is when you are administering a drug that results in a depression of consciousness that is defined as the patient is not easily aroused, but responds to noxious stimuli. Now, just given our patient population and the procedures that we need to perform, which are commonly very painful and very anxiety provoking, and we need both a level of pain control, amnesia, and sedation and relaxation, deep sedation is generally what we need to perform in order to get our jobs done and do the procedures that we need to do. And in deep sedation, cardiopulmonary function is frequently, I don't know about frequently, but it's often impaired, and therefore really needs a team approach and a procedural approach that in which the providers are ready and able to intervene in terms of some of the adverse effects and some of the respiratory depression and some of the impaired cardiopulmonary function that you see with deep sedation. Now, we're going to get into that a little later. And then from deep sedation, you move into general anesthesia, which is the same as deep sedation, except for the fact that it's a drug-induced depression of consciousness in which the patients are not arousable at all. They're not responsive to any sort of stimulus. And in the ED, occasionally during deep sedation, you'll move into temporarily, even momentarily, into sort of general anesthesia, in which the patient's really not responding to the painful stimulus or the noxious stimulus that you are inducing with, say, mobilization of a dislocated joint. You can put the joint in and they don't even feel it. That's, technically it's general anesthesia because they're not responding to stimuli at all. But it's typically very, very quick in the emergency department and very short-lived, as usually it's either a dissociative state with ketamine or it's some deep plane of sedation induced by the use of propofol or etomidate. Now, the important thing about general anesthesia to recognize is that it is expected that cardiopulmonary function will be impaired. And people who are doing general anesthesia, such as in the operating room, they are oftentimes providing the general anesthesia and simultaneously taking over the airway and the hemodynamic system because they know that the cardiopulmonary axis is going to be impaired. And that's kind of the difference between general anesthesia and deep sedation. So procedural sedation and analgesia as a whole includes all of these levels: moderate sedation, deep sedation, even transient general anesthesia, and it involves adults, pediatrics, and with moderate sedation, it's typically achieved with fentanyl and midazolam. Deep sedation and dissociative sedation is typically achieved using the general anesthetics, propofol, ketamine, and etomidate, at least in our facility and in most. And traditionally, these are separate procedures, and different providers have different credentialing for utilization of different medications and achieving different targeted levels of sedation. But emergency physicians are board certified and credentialed in providing emergency department procedural sedation, which encompasses all of the levels and all of the drugs, and both at adults and pediatric patients. So we really need to be prepared to take care of any patient. As you know, we never know who's going to come through the door, and so we have a single policy and procedure which encompasses the entire spectrum of patients and sedations that we use. Okay, So that's the definitions part, and now let's get into some of the policy and procedure. So the ED sedation team, the question being, what personnel are required to be at the bedside to perform a sedation in the emergency department? And first of all, you have your patient and you have a monitor, and the monitor needs to have continuous monitoring of cardiac rhythm, pulse ox. We do require end-tidal CO2 be applied and monitored throughout all sedations in the ED, including moderate and deep sedation. We also, and then blood pressure and heart rate, of course, are part of that. And there's some intra-procedurally, you should really be documenting these every 5 minutes, and then before and after the procedure, a little bit less so. But this needs to be continuously hooked up to the patient. So the providers that need to be present at the bedside are the emergency physician and the EDRN. This is the minimum number of personnel requirements that we have at Barton. The emergency physician is both the sedationist and also the proceduralist in this model. And the EDRN is both documenting and assisting with any sort of rescue interventions that occur, such as hypotension or any sort of airway scenario that may occur in the setting of a procedural sedation. But the emergency department physician is ultimately responsible for the patient selection, the drug selection, the informed consent, and administering both the sedation and performing the procedure. At our facility, we strongly encourage respiratory therapy to be present at all sedations, and they typically are. They are not, however, mandated, just because there may be a case from time to time where someone comes in and needs something emergently, and the respiratory therapist isn't immediately available. So you can proceed with the procedural sedation without RT at the bedside, but they are very strongly encouraged because they just provide another set of eyes on the airway and watching the end-tidal waveform, etc. Very helpful to have respiratory therapists at the bedside. And then the equipment that you really need to have at the bedside is advanced airway equipment at the bedside for sure. Specifically, some form of positive pressure ventilation, including a bag mask at a bare minimum, if not a supraglottic device. Suction, anything that you're going to need for any sort of airway complication or adverse event, something for oxygen delivery, and then you'd really need to do this in a room where the crash cart is immediately available in case of a adverse effect, such as a arrhythmia or hypotension or a cardiac arrest, all of which are exceedingly rare, but are certainly on the list of potential adverse effects that we need to be prepared for. Occasionally in the setting of emergency department sedations, a second proceduralist can come in handy. Most often in our patient population, we see this with orthopedic procedures in which we will call the orthopedic specialist in to perform a procedure while we do the sedation. This can also be a second emergency physician. It just really depends, and it really depends on the case and what's going on. It's not mandated, but it is encouraged to have a second physician there if you feel like that's something that would help the procedure or facilitate the sedation. Okay, so let's jump into some pharmacology and talk about some of the drugs and the agents that we use in our facility. So first and foremost, we're going to start with ketamine. Ketamine has become probably one of the more commonly utilized agents in procedural sedation in the emergency department and in acute care settings in general. Ketamine has some really favorable clinical effects that make it a really great agent for this purpose. And in children, for example, it is by far the most commonly used agent for procedural sedation. Let's talk a little bit about ketamine before we get into some of the adverse stuff, because ketamine is so unique and it has so many uses. This slide here, the ketamine brain continuum slide, kind of represents how, as you move up in the dosing, the dose response curve is quite unique in that at different doses you have vastly different clinical effects. In low doses, it's being used for just pain control and analgesia, and has very little psychotropic effect or sedation effect at all. And then as you walk up into the dosing, you see some unusual effects, and then as you get a little higher into the dosing, you end up with the dissociative doses, which is typically what we are targeting in procedural sedation. I'd like to take a moment just to point out there's a physician, Ruben Strayer, who's just got some excellent talks on ketamine, and if you're interested in looking at some of his work, here's a link to an excellent talk. So ketamine is a dissociative anesthetic, and one of the hallmarks of ketamine is that as a single agent, it provides both analgesia and amnesia, which are kind of the hallmarks of sedation, and it also provides relaxation and sedation to some extent. And those are kind of the three pillars of a successful sedation: analgesia, amnesia, and sedation. And with ketamine, you can achieve all three of those things with a single agent, which is why it's kind of felt to be sort of the ideal agent for a lot of procedural sedations. Ketamine is a bit of a hemodynamic stimulant, and I think anyone who's used it has seen a little bit of tachycardia and a little bit of hypertension. And this is mediated as it's kind of an indirect sympathomimetic and results in some catecholamine effect, albeit fairly mild. You will see some of those things. And one of the greatest benefits of ketamine is that it seems to maintain brainstem function. So respiratory drive doesn't seem too affected, and they seem to maintain reflexes such as airway reflexes and protective reflexes against aspiration. So this is a excellent target, excellent medication, although it has its limitations, and we'll get into some of that. And the drug itself causes like this incredible loss of perceptual reality, sort of the lights on but nobody's home, and which is where it gets its name, dissociation. Ketamine has multiple clinical applications, and I think that we've all been seeing this in recent years. We're starting to learn more and more every day about the many applications of ketamine and the NMDA receptor, and its role in many different states. At low doses, ketamine provides really effective analgesia, very safe analgesia, and these are very low doses. We've covered that in a separate talk. It's also been used for asthma, as it seems to have a little bit of bronchodilator effect, alcohol withdrawal, agitated delirium, depression, suicidality. It's an excellent target for rapid sequence intubation, and also is being used for opioid withdrawal, among other things. But I think by far and away its most important role is in procedural sedation and analgesia, which is what we're talking about today. Again, we're just going to talk a little bit about this unique dose response, this so-called ketamine brain continuum, just briefly, as we've talked about this elsewhere. At low doses, 10 to 30 milligrams in adults, given slowly, provides analgesia and has very little sedation effect, or very little CNS effect at all. As you walk up the doses, you get into a area that Dr. Strayer has coined the quote-unquote recreational dosing, and indeed ketamine is abused and used for its euphoric effects and its sort of hallucinatory effects in the community. It's kind of a rave drug. It's kind of a party drug. It's reportedly quite euphoric and quite popular. As you walk up the doses into, say, 50 to 100 milligrams, you get into an area that some people call like sub-anesthetic or sub-dissociative. And, say 50 to 100 milligrams to an adult, this dosing range is highly unpredictable, just to put it simply. Some people will kind of partially dissociate. Some people will get very euphoric. Some people will get extraordinarily dysphoric and have terror reactions. And this can be a little bit of a surprise every time you kind of walk into these doses. So I personally try to stay away from these doses unless I'm using it in combination with some other sedation agents such as propofol or benzodiazepine. But in general, that's something to be done under rare and unique circumstances. And then you get up into the dissociation dosing, and that's like 1.5 to 2 milligrams per kilogram, so greater than 100 milligrams IV to an adult. You tend to get pretty reliable, predictable dissociation each time, especially at 2 milligrams per kilogram, which is sort of the recommended dose. So for procedural sedation, which is the topic of conversation today, the dosing really is 1.5 milligrams to 2 milligrams per kilogram IV, or 4 to 5 milligrams per kilogram IM. And this is to get the dissociation effect. And so for adults, that's around 150 milligrams, and for children, depending on the size of the child, it's 20 to 50 milligrams IV and 40 to 100 milligrams IM. It is worth noting that with ketamine, unlike etomidate, we'll talk about in a minute, the dose for procedural sedation is the same as RSI. Okay. So let's talk about the adverse effects. These are the things that we need to be prepared to deal with when we're using ketamine at dissociative doses, and at any dose really, because we are using it for a variety of clinical applications. First and foremost is this concept of emergence phenomenon or psychiatric distress, dysphoria, terror. I have heard all sorts of things from patients and on the internet about ketamine's adverse psychiatric effects, feeling like you're falling infinitely, you can't see your arms, there's blindness, temporary blindness, very profound hallucinations. Many of these are euphoric, and some patients do fine with that, but they can be quite dysphoric. And anybody who has seen an adverse psychiatric effect or an emergence phenomenon in a patient understands that this can be quite horrifying. And although it's easily managed, you got to be ready for it. So how do we deal with that? One thing that has been shown in controlled trials is that giving a couple of milligrams in the study, I think it was 2 milligrams IV midazolam to adults, has been shown to reduce some of these psychiatric effects. And that's one way that you can sort of preemptively try to avoid it by the co-administration of Versed. Other ways that I found to be very effective are pre-sedation coaching, like getting the lights down, calming the patient, really talking the patient through it. Here's what to expect. Here's what's going to happen. Here's what you might feel. Go to your happy place. So pre-sedation coaching and also coaching as they emerge is highly effective and is very important to do. There are also people who are talking about, including myself, this is kind of my approach too, is having propofol at the bedside so that when they do start to emerge from their dissociative state, if they start to enter a dysphoric reaction that you feel needs treatment, you can bolus them with small doses of propofol as they metabolize the ketamine. And that works out really well as well. Although I'm not aware of any data on that. So that's the psychiatric distress. Ketamine is emetogenic. It causes nausea and vomiting, as all sedation agents do, all general anesthetics do. And this can be intra-procedural, although it is much more commonly after the procedure. There is some data that suggests that pre-sedation on Dancitron will actually reduce the incident of ketamine-induced nausea and vomiting. So that's something to consider, is giving Zofran prior to the sedation. Hypertonicity. Anyone who's used ketamine at these doses has seen patients sort of flex up and become somewhat rigid and hypertonic in their muscular system, and this can be a bit of a problem for, say, orthopedic procedures when you need to mobilize a big joint or do a big fracture reduction and the patient's kind of flexing. So occasionally this is a problem, and it can be treated very easily with a low dose of a benzodiazepine or the co-administration of propofol. I'm not aware of any data on that, but that's something that I've experienced, and that's generally how people approach the hypertonicity problem. So this, I think, is the most important thing. The sort of dirty little secret of ketamine. Everybody says, it doesn't affect the airway, but it absolutely does. And it does so, it can cause apnea and hypoventilation by a variety of mechanisms. It can cause central apnea, it can cause laryngospasm, it can cause the patient to position their airway, which causes upper airway obstruction, and there are many different mechanisms. So this is why, an airway competent team really needs to be at the bedside performing these procedures, and the emergency physician is really responsible with the help of the RN and the RT for really monitoring that airway continuously during these sedations. Most of the time, this is kind of a positioning issue. Sometimes they'll flex their chin down and kind of obstruct their upper airway, or become a little bit hypertonic in their head and neck musculature. And usually airway repositioning will fix the problem. Occasionally you have to go down the algorithm of, say, laryngospasm if you're hearing stridor, which is typically deepening the plane of sedation by giving either more ketamine or giving a bolus of, say, propofol or benzodiazepine. Positive pressure ventilation, and then ultimately RSI and paralysis if necessary. That's exceedingly rare, but it does happen, and that is why we need to be prepared to manage these kinds of complications. The other thing is that it's been noted that slower infusion rates tend to result in less apnea and hypoventilation with ketamine. Sometimes, just like all of these lipophilic anesthetics, they go right to the brain when you put them in the IV. And the faster you push it, the more likely you are to see apnea. And so a little bit of a slower infusion rate is generally recommended. And some people have talked about, just putting it in 50 cc's of saline and running it in, although that might take a little bit too much time. But a little slower infusion rate might help with this one. Okay, so let's move on to propofol. Propofol is so effective at producing sedation conditions. It is definitely one of the more popular agents over the last couple of decades, specifically in adults, but also in children. And it is an incredibly effective and useful agent to be a master at, which is why we're going to talk about it, because we use it a lot in our department. Propofol is also so effective at causing hypoventilation and hypotension that it is to be expected. In this agent, you really need to be ready for some hypotension. It acts as a direct vasodilator, CNS depressant, myocardial suppressant. It frequently causes hypoventilation and apnea. And the beauty of propofol is those effects are mediated by its vanishingly short half-life, which is why we love it so much. It really only lasts a couple of minutes. So that is probably the most important and positive attribute of propofol for emergency department procedural sedation is the onset is really fast, anywhere between 30 seconds and a minute, and the duration is very fast, 1 to 3 minutes for a single dose. As you're giving more doses and titrating doses, you have to understand that it's going to build up and last a little longer, which is where most people get into trouble with this drug. And so it does get used very differently by different providers. There are several different dosing strategies that people swear by. Essentially, you can break that into two different categories. One is giving a healthy slug of a single bolus of 1 milligram per kilogram up front, which usually produces the sedation conditions you need. And other people really like to titrate doses of, say, 0.5 milligrams per kilogram, followed by another 0.25. The key to the titrating of propofol is that you have to give it a little time. You have to give it about 60 seconds. If you start giving multiple doses and not waiting long enough, you get accumulation, and you will start to see some pretty significant longer lasting effects and apnea and hypoventilation and things like that. So you got to be watching the clock when you're doing the titration approach. So the big adverse effects with propofol, as we kind of alluded to, are respiratory depression and hypotension. Respiratory depression is very common with propofol, although it is very short-lived. So it's very important to pre-oxygenate the patient, get all your airway equipment at the bedside, have a bag mask available, and having some way to provide positive pressure ventilation. Pre-oxygenation is key because, if you get someone pre-oxygenated to the point of sort of nitrogen washout, they can remain oxygenating for several minutes with healthy lungs. So pre-oxygenating is key when you're using propofol. Hypotension is common. It's typically not a big deal. It's usually very transient. But occasionally it can be persistent, and in patients who don't tolerate hypotension well, you need to be prepared to, either preemptively give volume prior to the sedation, knowing that you're going to get some vasodilatory effect and some hypotension. You might want to have push dose pressors at the bedside, which are in the crash cart. You can use epinephrine. There's also phenylephrine, but epinephrine is more readily available. And you really want to try to limit the concomitant use of opioids. That's a kind of a discussion on its own, but the combination of fentanyl and propofol, or an opioid and propofol, really will result in more hypotension and respiratory depression. Okay, so moving on, a couple more minutes here. We're going to talk about etomidate, and etomidate is sort of the third most common agent that we use in our facility. It's an excellent agent for procedural sedation for a lot of things. There are many providers that really swear by it. It has its pros and its cons, which we'll get into. The one thing about etomidate is very fast acting. Peak effect is in a minute or so, and you get sedation conditions very quickly. We know this because we're very familiar with etomidate, using it for rapid sequence intubation. The thing to recognize that with etomidate is it lasts a bit longer. About 8 minutes or so is sort of a good rule of thumb. So you have to be prepared to have a sedated patient for 8 minutes, and most of the procedures we do don't take that long. So it's important to recognize that you're going to be sedated for a little longer than, say, with propofol. Now, let's talk a little bit about the dosing, because unlike ketamine, where the dosing is the same for RSI, With etomidate, the dosing for procedural sedation is 0.15 milligrams per kilogram in a bolus. And that is different than RSI. That's about 10 milligrams to an adult. And as we know, when we use it for RSI, we're giving a little bit more, like 20 milligrams or even 30 milligrams. So it's about half the dose for procedural sedation. So etomidate has some unpleasant and a little bit unfortunate adverse effects. Number one, it does cause respiratory depression, and all of these do in some respect, with the exception of ketamine. It has different mechanisms. It can cause hypoventilation and apnea, but this actually causes central respiratory depression. So pre-oxygenation and having positive pressure ventilation and bag mask ventilation at the bedside is key. The other thing that ketamine or etomidate is known for that's not listed here is vomiting and emesis. And again, most anesthetics are known to cause emesis and nausea, but etomidate has gotten a nickname evomitate in the past because it is quite common, anywhere from 10 to 20%. So that's something to keep in mind. The other thing that people maybe not so familiar with is this pretty profound myoclonic activity, even sustained myoclonic activity that looks almost like a seizure. And albeit transient, it can be quite distressing. And in some reports, it can happen up to 10 to 30% of the time. So you have to be aware of this and you have to recognize it. It can cause a lot of anxiety for the sedation team. So let's just summarize and finish this off by talking a little bit about how do you select the right agent for your patient. Everybody's different, right? Everybody comes in with something. If they need procedural sedation, you have to look over the patient, do a pre-sedation evaluation, which is what all that paperwork's about. Think about what the patient needs, how long the procedure is going to be, what the patient will tolerate, and kind of choose your agent there. So just as a summary slide, and I know this is a busy one, the pros of ketamine are that it's hemodynamically stimulating, maintains brainstem reflexes and respiratory protection, and also it has very predictable intramuscular kinetics. So that might be a really great agent for children in whom you can't get an IV because they're not tolerating. You can use it intramuscularly. The cons of ketamine are, emesis and nausea and the psychiatric distress. We talked about how to manage those and how to expect those. So propofol, again, by far the most important positive attribute of propofol is its kinetics. So it has very fast onset, very short duration, which is why we love it so much. It's a very good target, profound sedation and amnesia. However, on the downside, it is much more of a hemodynamic depressant, a respiratory depressant, and you have to be prepared to manage those scenarios as they arise. Etomidate, again, it's considered hemodynamically neutral because it doesn't really cause too much hypotension, doesn't really cause too much hypertension. It doesn't have much effect on the cardiac rhythm or rate. This is kind of why we like it so much for RSI, in these critically ill patients. It doesn't seem to affect the hemodynamics much. It has a fast onset, fairly short duration, although a few times longer than propofol, so that's important to recognize. And then the cons of etomidate are myoclonic activity, which can be quite frightening, and it also is emetogenic and causes respiratory depression. So just knowing these drugs and getting very familiar with them is, more than half the battle. Just being prepared for everything will stave off any sort of demons and will allow us to provide safe and effective procedural sedation in our emergency department. So thank you very much for listening, and any questions can be directed to me, and appreciate your involvement in our sedation program.